Welcome to Put Your Heart Into It, the HVC podcast centered around educating providers and staff about common clinical scenarios so that we can better treat our patients. Podcasts on this account are meant for educational purposes only and should not be used as a substitute for medical diagnoses or advice. If you have any clinical symptoms or medical questions, please consult a licensed healthcare provider.
Thank you again for everybody for joining us on this Saturday morning. My name is Pavani Kolakalapudi, one of the cardiologists here, and I can't believe we're in the 15th year of this, so thank you for all of you in the community who's been there since day one. Appreciate it. So the title of my talk today is Menopause Transition. I call it a critical window because that's kind of how I want us to approach this lecture, as it is a finite, time-sensitive area where we can actually, the actions we take, the things that we measure, biomarkers, can change the cardiovascular trajectory for half the population. So I hope I'm going to challenge you to think about cardiovascular menopause transition not only as a reproductive milestone, but a cardiometabolic event. All right, so I'll start with my patient. She is very unique. She is very young to have had established coronary atherosclerosis, meeting in RCA, PCI to our RCA for unstable angina a few years ago. She is a mom of 3 kids. She's a teacher. She plays tennis, and tennis is actually what made her feel her shortness of breath symptoms, seeking cardiac care. She's done well, by all clinical means. Her LDL is great. She's on high potency statin therapy. She's doing great. Almost in passing, at the end of our visit, she says, "Hey, I'm having more fatigue. I can't sleep at night. I have some palpitations. Do you think I'm going through perimenopause?" So that's the patient I want you to think about as I go through my lecture, because we will see more younger patients with atherosclerotic disease, so much so that the PREVENT ASCVD calculator starts at screening at age 30. So that's the patient I want you to think about, and hopefully by the end of the lecture, you'll feel more comfortable answering her question. So the objectives today I have is, again, challenging you to see menopause transition as a cardiometabolic event, not just a reproductive one, recognizing vasomotor symptoms in association with coronary vascular disease, understanding differences, timing of hormone replacement therapy, as well as performing that risk assessment in our perimenopausal patients. So I'll use this as the straw reproductive aging, and you can see here that towards the end of late perimenopause, you can see that symptoms of variable vasomotor symptoms, risk factors, can start towards the late perimenopause. So symptoms can start even 3 years before the final menstrual period in a woman, and sometimes those symptoms can last almost 10 years. But there is a true inflection point where you see that towards the end here, towards the end where you see the FSH increasing at the time of the final menstrual period, shifting that acute change in our hormone and what cardiometabolic implications that has for women. But it is a time-sensitive change that happens. And what does that change show us? That, again, that decrease in estrogen, increase in FSH, that can also happen even before the final menstrual period, changes that shift for cardiometabolic health. Estrogen is involved in many different regulations for us, and the decline of it can cause more ovarian aging. Increase in FSH especially decreases your lean muscle mass. It increases your insulin sensitivity. It produces visceral fat all through lipogenesis in the liver. So some women can have fatty liver disease that shows up at this age, insulin resistance at this age, and also can increase that carotid intermedial thickness. All of these risk factors can show up for metabolic disease. And this is the SWAN study, the study Women's Health across the nation. This is the longest longitudinal study that took women from 1996, ages 42 to 52, and kind of followed them over the decades. And so you can see here, using that reproductive stage and also applying it to that final menstrual period, everything changes. Waist circumference goes high, HDL is lower, glucose is increased, your triglycerides are higher, and your blood pressure increases. Those are all risk factors for metabolic syndrome. And all of these are happening in that time period. So again, I want you to shift that thinking of menopause is just a reproductive change. It is a cardiometabolic risk factor, and it's showed through longitudinal studies over the decades that it's a time-sensitive period, not just to discuss in an OBGYN office, but firmly belongs in conversation with your primary care doctor or your cardiologist. So that's why I want to say, use that transition. Use that patient who's coming to you for lack of sleep or palpitations as a teachable moment for primary prevention. And again, challenge what heart disease is. Heart disease is not a disease of older men, gray-haired men, but it can look like all of us. Half the population in the room, and about 21 million women experience menopausal symptoms per year. So this is a big moment for us to kind of use that information, use that time period to have that primary prevention talk. So shifting to vasomotor symptoms, it's not just a discomfort issue. It's not just a hot flashes, they'll go away, but understand why that is and what implication does that have for coronary artery disease. Vasomotor symptoms are described as typically hot flashes, palpitations, lack of sleep that can occur for severe symptoms can be daily, 6 or more days over a 2-week period is considered to be severe. This is the most common symptom that women can experience. But why is that? Why does that happen? It is estrogen actually plays a role in the hypothalamus to regulate temperature. This is the same system that protects us when we have a fever, the same system that helps us understand what shivering is when we're cold. And that gets dysregulated when there's lack of estrogen, a shift in estrogen. That pathway is dysregulated. So you're more sensitive to heat, you're more sensitive to cold, and that can increase increases in temperature, can increase inflammation and endothelial stress. And that is the perfect setup, unfortunately, for endothelial dysfunction. You have that inflammation, that heat increases your TNF-alpha, increases your oxidative species, more inflammatory factors, and it decreases the ability for your blood vessel to make nitroglycerin and use nitroglycerin. That can eventually change structural changes, increase carotid intima thickness, you have more deposition of collagens along the blood vessels, and you have increased sympathetic tone, which can also trigger autonomic instability, all leading to large artery stiffness, hypertension, and something that we always pay attention to as cardiologists, increased afterload and onset of diastolic dysfunction. Almost all of our patients seem to have this, a lot of the echo reports that we read, impaired relaxation, diastolic dysfunction. We know it does also disproportionately affect women postmenopausal age. But all of these can be seen how it can just be from that increased heat, inflammation, triggering a cascade of events can eventually increase your risk of heart disease. And there's no other, pathology that kind of intersects both the menopause transition symptoms and couples that with coronary vascular disease and microvascular disease. Microvascular disease is described as a disease of the small blood vessels. And you can see here how the blood vessels are impaired by impaired vasodilation, vasoconstriction, myocardial remodeling, all of the things that we can see that happens in women with postmenopause and high vasomotor symptoms. So how does this patient look like to you in your clinic? It could be a postmenopausal woman coming to you for anginal chest pain. I have chest pain when I exercise. You do a heart cath or a diagnostic angiogram, and they have no coronary artery disease. They say, hey, it looks fine, you're normal, go home. And they're back in your clinic still having chest pain. How do you approach that? What's the next step to do? So we have coronary PET here at HVC, where we can, again, test the entire microvasculature to see how is their coronary flow. So they might have a normal stress test, completely normal stress test. When we use our PET CT scanner, you can see they have no coronary calcification on the image there. But you can see on the top right, their flow reserves are all low. And you can see LAD, circumflex, RCA global, everything is below 2. That is considered to be microvascular disease. So you can more confidently tell your patient, this is a disease of the small blood vessels, and they can usually respond better to amlodipine or Ranexa. But we have different tools to help us diagnose and more quantify what that angina really is, what level of degree that vascular disease is using cardiac PET. So again, let's not dismiss vasomotor symptoms or just hot flashes, they'll go away, you need time, but really try to understand how often are you having them? How much during the day are you having them? How is your blood pressure doing? So just really try to understand that. That's just the tip of the iceberg, and the problem really exists deeper down into endothelial dysfunction. Inflammation can lead to vascular remodeling. Briefly on the evolution of hormonal therapy, I think I'll just keep this, non-controversial as possible and say that what I think the Women's Health Initiative did wrong probably was take older women who are not having any symptoms and gave synthetic estrogen to see what the outcomes would be. Of course, we all know that increased their risk of stroke, cardiovascular disease. And her study was done in women for secondary prevention. So there are actually women who already had established coronary artery disease and were given oral estrogen, again, showed to have increased risk of stroke and heart disease. More contemporary studies like ELITE and KEEPS are actually more appropriate for those women within 10 years of menopause. Younger, without onset of atherosclerotic disease, were shown to actually have it safe to take menopause therapy. And some studies also show there is reduced CIMT progression, that intermedial thickness progression, and transdermal in the KEEP study was even safer. And why is that? Because when you actually give it to a younger patient within 10 years of menopause symptoms onset, age less than 60, their endothelium is still reactive. It can still, hasn't set in, the collagen hasn't set in, the increased interval thickness hasn't set in, so that blood vessel is more responsive to MHC or menopause hormone therapy. Whereas if you're already giving that to estrogen to somebody with a disordered endothelium, you're actually causing inflammation and leading to plaque instability. That's why, again, the timing hypothesis matters. Who you're giving it to matters. Younger patients, symptomatic patients without already established CAD. The KEEP study showed transdermal is safer than oral. Why? Transdermal, or a patch or a gel, does not go through the liver. It passes the bypass. Bypasses the liver, so it does not trigger those prothrombotic proteins in the liver. So that's why I think either our intermediate to high-risk patients, they can safely take estrogen to control their vasomotor symptoms. Again, I want to make that point that hormone replacement therapy or menopause therapy is not given for cardiac benefit. It's really only given for vasomotor symptoms and other symptoms that the patient is having. But progesterone is also considered to be safe. Micronized progesterone is metabolically neutral. And a brief talk on testosterone, given in low doses with your OBGYN, I think it can positively impact your body composition, insulin sensitivity. And briefly what about my high-risk patients? That my patient that already has established coronary artery disease, what are her options? There are still plenty of other non-hormonal options that we can think about. Paroxetine, citalopram, Paxil you can be given, but just be mindful of their cardiovascular implications too. Some of these medicines can increase your QT prolongation, especially if given in higher doses. Venlafaxine, desvenlafaxine, very effective for vasomotor symptoms, but increases your risk of hypertension and tachycardia. The newest one, that neurokinin antagonist, fezolinetant, I practiced that one, does not have any cardiac implications, no QT prolongation, and seems to be very beneficial for treatment of vasomotor symptoms. And that is the same receptor that I showed you on the picture for the hypothalamus where that works, that acts as that estrogen. Gabapentin, I think this is Dr. Bott's favorite medicine of all time, can increase your risk of having, peripheral edema, fluid retention, increased risk of MI if used, excessively over a long period of time. Clonidine has been previously used, but we all know there's hypotension and dizziness, poorly tolerated in general. And oxybutynin can also be used, but it can also cause sometimes tachycardia. So it's very important to understand that even if you choose non-hormonal therapy, really important to understand what their cardiovascular side effects could be as well. And so how do I risk assess? I strongly believe that having that conversation about perimenopause and that shift in the reproduction has to be coupled with your primary prevention talk. And so again, we use ASCVD, Prevent Calculator, to understand who is that low-risk patient that can safely take an oral estrogen and who should I avoid oral estrogen, not triggering increased risk of clotting factors. So low-risk patients, recent menopause, normal weight, normal blood pressure, an ASCVD or a Prevent score now of less than 3 or 5. Intermediate risk, anybody who has risk factors. They might still not have any coronary artery disease, but they certainly have diabetes or a smoker, or their hypertension. They might be safe to use it for transdermal options. And high risk, again, congenital heart disease, somebody with a history of PE, VTE, stroke, or ASCVD risk score of greater than 10%. But again, even the highest risk patient, they can still have topical estrogen, vaginal estrogen if they need to for urogenitary symptoms. So I don't want you to deny patients of what medicine they might need for their symptoms. So, Prevent, ASCVD risk calculator, which one do I use? I think the Menopause Society just represents that you just got to do it. It doesn't matter what calculator you use, whatever you're talking about to them, but you have to do the cardiovascular risk assessment at that time when you're talking about menopause symptoms. Just do it. So to help our patients and help our clinicians in the community, we've come up with this tool called IRIS. It stands for Index of Cardiovascular Risk During Transition. And this is will be available on our HVC website, but you can use the QR code. And this is just meant to open up that conversation. Somebody like Harsh Patel, I don't know where he went, but somebody like Dr. Ahmad, who is going to talk to that patient about AFib ablation and what route to do, he should feel comfortable if someone's complaining to him about palpitations in that age group, say, hey, when was your last menstrual period? What can we do to identify your symptoms? So the calculator that we looked up has ASCVD risk score, has some, I think, still some places where you can enter lipoprotein A, calcium score if you have it, and then what are your symptoms? What are your menopause symptoms? Most common ones are reflected on there, and also add to their female specific, like history of preeclampsia, history of gestational diabetes, and it gives a nice little printable summary showing your risk as well as showing what your options are. So maybe a patient can use that to approach their physician, or you can use that at that moment of having that conversation. Let's look at your overall risk. Let's look at this more holistically. So again, in summary, the key takeaways are, I hope I've helps you understand that when you're having a conversation about menopause, please also reframe that conversation to talk about primary prevention. Aggressively monitor lipids, screen for hypertension, diabetes, subclinical atherosclerosis where available, like a calcium score, and check again for lipoprotein A. Recognize, understand, those hot flashes, they're not just discomfort, they actually can signal a cardiometabolic or cardiovascular risk. And treating matters. The age of the patient matters, the route of treatment matters, and how long you give it for matters. So that's my study. Sorry, one other thing I forgot to mention that I'll ask everybody to you, but what is one of the best things you can do to decrease that endothelial dysfunction during menopause transition? Dr. Ingalls, you can't answer. It's not a drug. Exercise, correct, I heard it, exercise. Exercise, because of the shear stress on the vessels, it actually increases the stimulus to make nitroglycerin and also helps increase your glutathione oxidase, which is actually it neutralizes your inflammatory markers. There's one thing you can also tell your patients, you have to exercise to help counteract some of those endothelial dysfunction. So that's my talk. Thank you.
Thanks for listening. Tune in next time for another cardiology-focused episode.